effect of a drug in a complex illness. And that's what we're trying to do with the randomised controlled trials. And that's why we need so many patients in those trials across many countries, many age groups, genders, many phases of the disease and many levels of severity. And then we can break out what is the actual effect of the drug on the outcome of the disease.
Only to add that there are a number of clinical trials that are ongoing. Mike has described the French study that I'm aware of as well. But there are a number of clinical trials that are ongoing that look at chloroquine, that look at a number of other therapeutics. And on the one hand, it's incredible to see this acceleration of research and development and this focus on the evaluation of therapeutics for COVID-19 patients, which is building upon a history of other respiratory pathogens that have plagued us. But the challenge is that many of these clinical trials are small in size, which makes it very difficult to draw any conclusions, which is why it is very important that we have these larger trials, these multi-site trials, the Solidarity trial that WHO is running, to be able to have enough cases to be able to get an answer to which drugs work safely.
Thank you very much. We have time for one or two more questions, so I'll try with Bloomberg and Naomi. Naomi, can you hear us?
Hi, yes, I can. Thanks for taking my question. Wanted to ask, we've seen some different approaches to quarantine in China and in European countries, with group quarantine used to good effect in China. Do you think that home quarantine will be as effective anywhere for people who are positive, or would central quarantine be needed in order to have the same success that China had?
Hi. So we get our terms right and we can explain ourselves properly. We tend to use the word isolation for someone who is a case confirmed. We tend to use the word quarantine for someone who's at risk of being a case, usually a contact. So on that basis, we advise that all suspect cases are tested and all suspect cases are isolated in an appropriate medical facility. I think nobody disagrees with that, where the capacity exists. When we come to contacts, it very much depends on the context and the intensity of the epidemic at any given moment. In low incidence areas where there are sporadic cases or clusters, we advise that all contacts should be quarantined. Ideally, that quarantine should occur in a place other than the home. And for this reason, one, because if that person gets sick, they may already have infected their family. But that's not always possible. So at least quarantining contacts at home with good health advice about not transmitting disease if they become sick, and with regular monitoring of that individual, is an option for countries. It is difficult to do that in the middle of intense transmission, where you might have hundreds of thousands of contacts because you're having thousands of cases a day. It is difficult to deal with that. So home quarantine of contacts is acceptable with appropriate information, education, and more importantly, a very rapid system of getting those people out of their homes if they become sick. I listened to the President of Singapore this morning, and he had a conference call with the Director General, and the clarity of that in Singapore, that ability not only to isolate cases but to rapidly detect illness in the contacts and remove those contacts should they become sick, was a central part of that. And as he said, that wasn't, they're using apps now to do that. They're testing apps, but they didn't do it with apps in Singapore. They did that with community workers, with public health workers, visiting the houses, checking on people, checking their health status every day and saying, how are you? Have you got a fever? Have you got a cough? And if a contact has developed a cough or a fever, they were taken immediately for testing. So yes, we need the information technology tools. They help. They are not the solution. Right now, we don't have an alternative to what we would have considered in the old days boot leather epidemiology. Public health practitioners, doctors, nurses, community workers working with communities to detect cases at community level. And the most likely person to become a case is someone who's been a significant contact of another case. And at the moment, in most parts of the world, due to lockdown, most of the transmission that's actually happening in many countries now is happening in the household, at family level. In some senses, transmission has been taken off the streets and pushed back into family units. Now we need to go and look in families to find those people who may be sick and remove them and isolate them in a safe and dignified manner. So that's what I was saying previously about the transition from movement restrictions and shutdowns and stay-at-home orders can only be made if we have in place the means to be able to detect suspect cases, isolate confirmed cases, track contacts, and follow up on the contact health at all times, and then isolate any of those people who become sick themselves.
Thank you very much. As we try to have a variety of different outlets being able to ask questions, we don't have quite often sports outlets, so I will call on Diane from soccer.com. Diane, can you hear us?
Yes, I can hear you. Can you hear me?
Yes, please go ahead.
Hello?
Yes, please go ahead with your question. Diane, let's try one more time. Can you hear us? We were hearing you very, very well.
Yes, I'm sorry. I'm having my phone. Hello, can you hear me now?
Yes, please go ahead.
There is such a discrepancy of information regarding the validity of masks, and I know that you have addressed this, and there's a great deal of fear regarding medical professionals having access to it. But is there any type of qualitative research that can confirm that the masks, wearing a mask prevents the spread for normal transmission in going to the supermarket, in day-to-day activity?
I can start, and perhaps Mike or the DG would like to supplement. So this is an area of very active research. There's a lot of use of masks globally for different diseases, for influenza, for other coronaviruses, for this particular outbreak. But there isn't a lot of quantitative analysis of this. And what we know works, we know that people who are sick and they stay home, that works because that prevents them from spreading the disease to someone else. We know that washing your hands works because we know that or using an alcohol-based rub, because that will remove the virus from your hands. We know that physical distancing works because that removes the opportunity to spread that virus from one person to another. We are working with a large group of people across the globe in our IPC specialist networks to look at the use of masks in various settings, first and foremost in healthcare facilities, so that we could better understand how PPE was used by healthcare professionals as they treated patients, in which types of departments they were working in, under which types of conditions, the severity of those patients. That's the real focus of a lot of the research right now to ensure that we protect our healthcare workers. So we are working with a number of groups across the globe. As those results become available, they will be published, they will be scrutinized, they will be evaluated by us and our partners to make sure that we are putting the best evidence forward and the best evidence-based guidance forward.
And I will take one more question because I've been getting messages. And obviously we apologize to all those that will not be able to ask their question today, but we will have opportunity this week. So I'll call on Gabriela Sotomayor to ask her question. Gabriela, please.
Thank you very much. Thank you very much, Tarek, for taking my question. Dr. Tedros, on testing, there are some countries that I think that they are not listening exactly. I mean, the message, they are not receiving the message. So just to clarify, because some countries are saying that it's useless to test. So in a country, for example, in a country when you have 1,000 confirmed cases and 2,500 suspected cases, how many tests do you have to do? I mean, just to have like a number or something, an estimate. Thank you very much.
The positivity rates on tests, the DG may wish to comment as to whether people are listening or not. But on the specific issue of tests, the positivity of tests or the number of tests, in general, where testing has been done fairly extensively, we've seen somewhere between 3 and 12% of tests being positive. If you get to a point where a tiny percentage of tests are positive, then the danger is you're either looking in the wrong place. It's reassuring, or you have to be very careful to ensure you can keep up that level of testing. So it's an issue of balancing the use of your test against their value. And again, it's like any detector system. Testing is a detector system. You can turn up and down the sensitivity of that system as long as the batteries last. So that's the issue. How long will your tests, the available tests, if you know I've got X number of tests available to me over the next month, then how am I going to use those tests over the next month? So countries have been limited by the number of available tests, and that's important. Countries have also had to ration tests according to the intensity of the disease in different parts of the country. So therefore, the return rate or the percentage of confirmed tests will vary. But we would certainly like to see countries testing at the level of 10 negative tests to 1 positive as a general benchmark of a system that's doing enough testing to pick up all cases. Now, it can be more or it can be less, depending on the circumstance. It's not an objective, but you really do want to see a lot more. You would be very, you know you're missing a lot of cases if 80 or 90% of the people you test are positive. You are probably missing a lot of cases.
And if I could just add to that, to say that a lot of the challenges that countries are facing, a lot of the argument that comes back is just, well, we just don't have enough. And so just to say what WHO is doing and what countries are doing is they're trying to find tailored diagnostic solutions to their needs, to meet their needs of their countries and the outbreaks that are happening in their countries. And that includes a variety of things that we are doing and countries are doing. The first is to increase the capacity of the labs, so the number of labs that can actually conduct that testing. So whether these are national labs or academic labs or private labs, but increasing that number of labs, increasing the number of people that can actually run those tests, finding individuals that can run those tests. The second is increasing the production and availability of tests. There's a huge number of tests that are on the market right now, thanks to the rapid sharing of sequences, full genome sequencing of this virus in early January. And then the third, we are working very hard to have a tailored support to country based on their need, based on what they have in their individual countries, whether these are benchtop or manual PCR kits, or whether these are automated PCRs, or whether these are high-throughput machines. There's not one single solution to increase your ability to test, but it is important that you continue to do so that you know where the virus is.
I think it has been said. Just wanted to add, testing is very, very important. I cannot even emphasize it more. There was a meeting of ministers. This was last Thursday, I think, and we had, some of the practices from 4 countries, actually, what they have done. The common factor in all 4 countries was the testing. Testing is important to understand the status of an individual, but testing is also important to see, what the situation looks like. For instance, from the presentations of the 4 ministers, we saw that when they test, they go back and check those positives, how they got the infection. Some of them could be from a church gathering or a religious event, or others could be in a bar or a restaurant, or others could be in a social gathering for some purpose. And then the testing is not about that individual. It becomes about the event that happened and how to really address such events. So the testing doesn't tell you just a story about one person. It's a story about what happened when that person actually acquired the infection. And that helps you to trigger your public health intervention